Welcome to Breaking Point, a podcast from CAPC, the Center to Advance Palliative Care. In this limited series podcast, CAPC invites healthcare workers from across the country to share their eye-opening stories from the front lines of the pandemic. Listen as they give us an unfiltered look at their reactions to the demands they've encountered and the coping strategies they've employed as they reach their breaking point. Your host today is Dr. Diane Meier.
Good morning, everybody. My name is Diane Meier, and I'm so pleased to welcome you to this week's episode of Breaking Point. Thank you for joining us, Donna Stevens, my dear old friend and colleague for many years, working to build access to palliative care in the United States. Donna is the program director of a program that we refer to by its nickname, OACIS. It's actually OACIS, and it stands for Optimizing Advanced Complex Care, Illness Support, and Palliative Medicine. And Donna's been leading and developing and expanding and innovating in that program for many years. This is in Pennsylvania at the Lehigh Valley Health Network in Allentown. So that's kind of a suburban, rural part of the country, not, a major, big urban center. So Donna, thank you again for taking the time to join us. And I would really appreciate just hearing the story of how you and your team and the organization in which you work have navigated the past couple of years.
Thanks so much, Diane. It's lovely to be here with you. Honored to be a part of this. We at Lehigh Valley have, about 8 hospital sites, something like that, but it's a fairly, we've grown over the last 10 years dramatically. It keeps happening, even amidst the pandemic. It strikes me how odd that is, that we can't handle the demand we have, but we're still growing. The network as a whole has, as many do, a physician group part of it, as well as the hospital part of it, as well as all the outpatient other services. And we at OACIS Palliative Medicine have dyad leadership, which is such a strong piece, I think, and was so forward-thinking from our visionaries to put together what was the administrative role, which is mine, as well as a clinical lead. And I report through the physician group. And my partner reports through the Department of Medicine. We have a section of palliative medicine and hospice within the Department of Medicine. When this all happened, the pandemic started back in 2020. The Department of Medicine is led by an infectious disease doc. And he was tasked to try and help all of us understand what was going on, being this such foreign territory, and no one had been here before. And so he started these COVID updates that happened when it first started really rolling to be informative, trying to help us what was happening in the world, as well as in the nation, as well as right here. And they really refined that over the years. It got to be less frequent when the surges weren't, really happening right in our face. But that really provided a foundation and a base for us to understand where we were, what the science was, how to center ourselves, and where the needs were. And I credit that to be just a huge piece to how we all felt connected, centered, and we understood the direction. So it was clear interface with senior leaders and clinicians and scientists that were actually figuring this stuff out to balance what was happening in the world. So that was an underpinning going on the whole time. And it fluctuated depending on where we were with the surges. And I think about our experience was encountering 2 major surges and 1 smaller one in the middle. So in the beginning, it was, complete chaos. Nobody knew anything. We didn't have the vaccines. There was fear, just tremendous fear, not only with people and their jobs here and seeing patients, but it was, what do we do with our kids? And there wasn't any daycare. And how do you navigate school? And God bless all those people that were navigating all of that at the same time. We did lose some people by virtue of that, but it was just, how do you manage all of that chaos? These were the challenges that we were going through. Knowing that there were different pain points for the network. We are an integrated network service, so we're very interested in our stakeholder needs, and that was needs of the network. And so at that point, it was burden. This is the first surge, burden in the emergency room, burden in the ICU, but very much inpatient focused. Outpatient, it was, as I mentioned, chaos. It was just madness because you didn't know, was it safe to do anything at that moment? Again, the vaccines weren't there yet. And so it was, full PPE, and then it was removal entirely from doing anything in person. And then we went to all virtual. By virtue of those two elements going on at the same time, inpatient being completely taxed, overwhelmed, and having outpatient kind of floundering, really not knowing what to do. The need was in the emergency room. And so by virtue of how we're structured, we understood that the emergency room was really being overwhelmed. And so how could we help? And we knew from the work that Sean Morrison had done and kind of got out there the information that we were following kind of what happened with Mount Sinai to say what's helpful. And they were really wanting palliative care. So we pivoted from our home-based team to do work in the emergency room. That didn't last very long. We had a pilot and we lost almost 3 nurse practitioners because of it, because people were having trouble balancing all of their needs at that time. But it gained political capital for us. It said, you guys care about what's happening with the whole group and how that can actually benefit us in the long run is one learning I had. You lean into these pain points and really understand where you have some flexibility and adaptability and try to address them. Then, we did actually add resources. We filled positions, got sort of, strong in some ways, and the vaccines were going up and the cases were going down somewhat at the next surge. And then the next surge happened and we called it a mini surge, but we didn't know where it was going. And that at that point, there was more of an issue around, did you get your vaccine or not? And the mandates. And we know that they're helpful, but there's so much misinformation out there. And so we were still, we were back to doing in-person visits, outpatient. They were back to kind of doing the same volume of work. But what was happening in our team was the tension was so high by virtue of still demand inpatient and still uncertainty about things that we started to have some real tension in the team that played out by virtue of, the inequities, certainly within healthcare, as well as what was happening with vaccine acceptance and racial inequities. And we have a multicultural team, and there was real tensions in terms of people just not accepting the vaccines totally on the team. Mm-hmm. And it became a breaking point for us, a real tangible, tense moment in one of our meetings. And which is very unlike us. I always say, if we don't hear laughter in any gathering, I start to wonder, and what can we do to kind of help people to feel more connected? And so we really embraced that moment to say, what can we do? And my friend Joanne Reich-Snyder, who I mentioned before, mentioned Amy Edmondson, who's done a fair amount of work at Harvard Business Review to look at about psychological safety, and that a lot of what's happening with fear and tensions between whether it's a medical hierarchy and whose role is what, or racial tensions or whatever it is, comes to fear. And so how can we provide safe spaces here? And so we did a fair amount of work on understanding what went into the feeling that people were against each other at that moment. It came out by virtue of vaccine acceptance, but what else was behind that, and how could we help people to feel safe? So we did a survey, we did an intervention with a retreat that was really well received, but we also did this thing where we did a deep discussion on what does it mean to feel safe. We were tired of the terms resilience and wellness and self-care, and what did any of that really mean? And our team, our subgroup of really talented professionals said, it's really about team connections. How can we feel better about coming together and relying on each other? Because I believe within all this work, it is the team that gets you through. It's who you have to rely on, who's next to you, and how can I trust them, and how can we all feel safe to ask questions, to make mistakes, to feel like we have a difference of opinion. So we developed a mantra that we say at the beginning of every meeting that talks about acceptance and being open to others' viewpoints. And it's been kind of our credo to say that, if we can all, state it frequently, it starts to seep in. And we really feel like we've come a long way in terms of acceptance and kind of cohesion. And that was during the second surge. The most recent surge then, which we're just coming out of, we were at, 140% capacity, really terrible scenarios happening inpatient. Now, the tension isn't quite as much, even though we all know that the unvaccinated are the ones that are really needing a lot of care right now. But it is, this particular surge then brought out the low staffing and how, there was so much need. We had unparalleled demand and unparalleled vacancies at the same time. And so that mass exodus of healthcare, which, by the way, we stayed full staff during all that. I'm very proud of that. We then had to think about what could we do to help in those scenarios. So there was a call on these updates to say there is mandates for all RNs to go and cover inpatient work. So we did that. We had one of our nurses do that. But it was also at these, the open access points, I can't think what they're called, the express care, the express care centers were getting overwhelmed by virtue of testing as well as anything to do with COVID. And so we had one of our MAs kind of do some shifts there and really went above and beyond in that regard. And then another one did some work inpatient, and she was specially trained to do some work to sit with patients. So the things that we always try and do is say, where are the pain points? What is the most important thing? And how can we help? Even though we are completely taxed clinically, how can we really look at how we flex roles and make sure that we are assuming that their needs are our needs, like what does that really look like? And so all those things really do help to, not only solidify our role, I think we're done solidifying our role. It really is about understanding the benefit of our perspectives and how our perspectives on care really address not only the patients in front of us, but our network and how we see each other in terms of our role with that. So it's been terrible, it's really been terrible. There have been many times where I just think, we can't do anymore. Like we just can't be, no one can stay here and do this work very much longer. But then we'd hear on the COVID update where we were within the surge and how we might be coming down a little bit. And that over the last 2 weeks, I'd say, really has meant the world to us to feel like, well, there's some reprieve at least. We're not where we need to be, but at least it's a lot better than it was. And so the vaccine issue was a real sticking point for us, and how that affected our team was pretty dramatic. But I think, now I think everybody would say we're very much on the other side of that, back to really feeling like, we want to be connected as much as we can. And that was the outcome of the intervention with the retreat, was that people said, we just really want more. We want to be able to talk to each other as people and have a real relationship, because that is the only thing at the end of the day, I think, that gets you through.
Yeah, I think that's been a theme in many of these breaking point discussions, that very much is about trusted human connection and relationship and prioritizing that.
Yes.
And I think it's fascinating that you mentioned initially your leadership's regular COVID updates.
Yes.
And those
Yes.
really were about reaching out and connecting to all
Yes.
staff and saying, we're all in this together.
Yes.
And you know everything I know, and there's no secrets. And
Yes.
you're not going to be blindsided by
Right.
urgency
And-
to communicate with you. And that is the same theme, basically, that
Yes.
you
Yes.
think about your own team when the
Yes.
vaccine disparities in terms of willingness to accept it came up. I wonder, you mentioned a mantra that you use in your, at the beginning of your meetings. Is that something you can say to us?
Yes, and if I had it right here, because I want to make sure that I get it right. I don't have it right here. I could get it, but I don't have it right here. Just we in OACIS Palliative Medicine strive to provide a safe space for all of our meetings or gatherings. And that means that we are open and respect others' viewpoints, regardless of whether they're the same as ours, essentially.
And that helped. That's
Yeah.
really interesting.
Yeah.
It seems so simple.
Yeah, but to state it, state it repeatedly.
Yeah, it makes it conscious instead of unconscious.
Yes.
Yeah,
Yes, exactly.
that's really remarkable. What is your perspective on, and it's very hard to have a perspective when we're still in the middle of it, but your perspective on the ways in which going forward, there are some innovations and some changes in how we do things that were so valuable that we're going to hold on to them, and which things, looking back, might we think about doing differently? I'm again really struck by the discipline you had of understanding where the pain points were in the system and pivoting to address those, which, as you said, bought you enormous political legitimacy and respect in your system. And I think we've also heard that from lots of other leaders like yourself. But what do you take away from what you and your team and your organization is still at the tail end of a third surge, but may permanently change?
I think perspectives have completely changed. There is no certainty about much anymore. I think we've all learned from that, I always think about it in terms of the flexibility and being nimble and what you're planning always. But I think in terms of, just people's roles, people are transitioning their role even on the team, which I think we should always be considering, is this the smartest way to use resources? Is there a different way to really meet needs than what we currently use? So I guess it's this feeling that you've ever gotten somewhere, it's very much of a journey, and you're always looking about, what are the road signs now and how does that change? And I guess the hypervigilance is really what we were at. We'd like to calm that down a little bit, but to still keep the whole notion that, we always want to be meeting the needs of those whoever we're trying to serve. And so that changes. And we certainly learned that in large part that changes dramatically sometimes.
Yeah, what's interesting at the meta level is we always think of ourselves in palliative care as meeting the needs of patients and families, which are infinite. And so we obviously cannot meet all of them, but you are focusing explicitly on meeting the needs of your colleagues and your organization, which is a shift in identity in some ways.
Yes. Yeah, that's really true.
And
we've also really taken on Schwartz rounds and focused it. So we had done Schwartz rounds, I've started it, I think, twice here. And we most recently have been focusing on COVID. and how that has really, we have unbelievable response that we've done it all WebEx, and still people are very involved, engaged, and really want that outlet for themselves. And we sponsor that. And I think that that is something that also has been something that they look to us to kind of provide for them. There are various ways that different large organizations try to meet the needs, the wellness, whatever we say, stress needs of their individuals. And I think that, to me, it just becomes so clear. It's become so clear over the last 3 years that people really want to feel heard. They really want to say what's on their mind. They don't want to put filters on. They want to say that it sucks and that they're just they don't know who they are anymore. They go to the grocery store and they want to yell at people. I mean, it's just real stuff. We've had a nurse recently say that she didn't want to learn the names of her patients because they were all going to die anyway. I mean, it's just horrendous what people have encountered. And so for me to, or for anyone to pass out a cookie pack, or, like, what? We really need to talk to them. We really need to hear them out. And they be validated that they have every right to be mad.
Yeah. And then to know that they're not alone with those feelings.
Exactly. I think that's the medicine. And I certainly think we've all learned that is a key part to, like, helping people get up the next day, really.
Yeah, that's been a really powerful theme, again, in these conversations about expanding our focus much more explicitly. I think we used to do it implicitly.
Yes.
Our colleagues,
yes.
To a more explicit focus of our time and attention on taking care of our colleagues as well. Just before we're coming to the end, before we close, just because some people don't know what Schwartz rounds are.
Oh,
they're fantastic. So could you describe what they are?
Sure. Been around for, I would say, over 20 years or so, but it really is an open forum to discuss the emotions that are involved with taking care of tough cases. And it's really meant for healthcare providers to feel like there's a safe space to talk about what's real, about not to fix things, but to really talk about the emotions involved.
Mm-hmm. And what's interesting is how the need for that exponentially increased.
Oh, yeah.
Increased because of the moral distress, which is always there in healthcare, but has been heightened enormously.
Absolutely.
During this pandemic.
Yeah.
Well, that's quite a tale, Donna.
I hope it's helpful.
It is incredibly helpful. I'm really impressed by your perspective over the time period and how the different phases led to different experiences for your team and different consequences. Initially losing several nurse practitioners because they liked working in the home and they did not like working in the acute care setting. And so that even though you were pivoting to where the need was, that might not necessarily fit the needs of your staff and the challenges that takes. The issue of very intense feelings around, which are representative of what's going on in the nation around vaccine safety and on both sides, not safe to be with people who aren't vaccinated, not safe to get vaccinated, that difficult, not rational process, and how your team healed through that. And then now in the Omicron surge, the willingness again to pivot the placement of your team members. And it sounds like the tolerance of your team for doing that.
They're very strong team. Yeah.
Yeah. And that's impressive. So Donna, it's been a remarkable tale you've shared with us of your intense experience over the last couple of years. I wonder if there's anything else you'd like to share. before we say goodbye?
It may sound gratuitous, but CAPC has always been a way for us to kind of frame and assist and get us through and to think differently and expand our perspective. And without the tools, that we availed ourselves of on CAPC, we wouldn't have been as nearly as adept at what we were able to get accomplished. So thank you for your leadership and all of CAPC's leadership. But I also feel like it's such a testament to the people who do this work. It's just humbling in every way. So it's an honor.
Well, you have made my day. Thank you so much, Donna.
Thank you, Diane.
Always.
Thank you.
Bye-bye.
Bye.
Thank you for listening today. For debriefings, the Emotional PPE Toolkit, and more, visit capc.org/COVID-19.